you've been involved in Fibromyalgia UK for about 2 decades, you said, which I make to be about 20 years. You have fibromyalgia yourself, and you've been volunteering with the charity, particularly helping with all the IT. So that's an absolutely invaluable role, I think, certainly through this last 18 months. You've been chair of Fibromyalgia UK. When I asked you, you said, and had to do a bit of maths. So somewhere between 5 to 7 years. And so you've obviously got significant experience in the charity and in the condition. And we're absolutely thrilled to have you this afternoon to share some of that information, knowledge, intelligence with us, really. We're very keen to hear both some basics about fibromyalgia, about the work of Fibromyalgia UK, but and inevitably one of the things people are very interested in is what do people say really helps with relief here? And also, can you tell us any thoughts you've got in terms of scanning the horizon for the future? What kind of research is coming up? Who are the names to watch? So we really look forward to hearing from you. Thank you so much.
Well, thank you very much, Carolyn and the team, for having me on. It's a pleasure to be here. I'll try to answer all the questions that you have. I have a slide presentation that I'll go through that will cover some of them, I hope. But I often find that after the presentation, the questions come in. That's the most interesting part because you don't know what's going to come. So what I'll do first of all is I will share my screen so you can see the slides. And yeah, I suppose I should cover the first thing. How long have I been chair? And why does it take me so long to actually answer that question? It's just one of those things that I don't really keep a note of. It's a date, it's something I can look up. But yeah, as I said, I've been involved with the charity for close to 2 decades now. Pretty much within a week of being diagnosed, I get involved with the charity. But let me see, we'll share that. So hopefully you can see my screen now. And yeah. If that's okay.
Yeah.
So
good.
First of all, Fibromyalgia Action UK, and this talk is fundamentals of fibromyalgia. We do these quite a lot, normally to employers, to social prescribers, to anybody that really wants to find out a little bit about the condition, about the charity. So first of all, we always start with what is fibromyalgia. It means, I was going to say it means different things to different people, but I think what I'm trying to say is everybody that has the condition sees it through their own eyes about what their experience of it is. And that changes depending perhaps whether you have medication that helps you or whether you are existing, not really getting much help from medication. You will have a different view about what fibromyalgia is to you. But it really is a condition that's characterized a lot about widespread pain. It's often said as chronic pain. The word chronic, people sometimes think about it being severity, but chronic actually, as you will all know, is about the fact that it goes on for a long time. It's the length of time rather than severity. But you won't have fibromyalgia just in your arm. You'll have it all over the body. But it's accompanied by fatigue and exhaustion. And cognitive issues, non-refreshing sleep, it all comes together to try and make your life a little bit more challenging than it otherwise would be. There are other symptoms that go along with it, comorbid conditions, but these basic elements, the pain, the fatigue, the non-refreshing sleep, fibrofog, these are the basic blocks of fibromyalgia. You have to have these in order to have fibromyalgia. It has a huge impact on people's lives. It takes away choices, it steals time. It affects people differently. And it can take a long time before you're diagnosed. And it can involve you changing jobs, having a different role within your life. We often grieve for the life that we previously had. But who's affected by it and why? And these change over time. In the time that I've been involved with the charity, it used to be we would cite 1 in 50, and we now cite 1 in 20. The statistic is 2.9%, sorry, yeah, 2.9% to 4.7% was prevalence figures that were carried out across 5 European countries. Depending on where you are in the world depends what that prevalence figure will be, but 1 in 20 is a nice simple way for people to understand it. It I think equates to about 2.5 million within the UK when we were thinking about maybe population 2015, 2017, around about that time. So it'll be more than that now. And it impacts more women than it does men. It used to be the gender balance was 9-to-1. It's now 7-to-1. We think it might actually be a little bit less than that, but I'll talk a wee bit more about that in a minute. And why does it happen? Where does it come from? And we think that there is perhaps some sort of genetic aspect to it, some sort of passing on maybe through the family line, but because somebody, your mum, has perhaps had the condition, doesn't mean that you will get the condition. Think of it as a risk factor, and there might be an environmental trigger, whether that's a car crash, giving birth, some sort of trauma, whether it's an infection, an emotional trauma, or unknown. I'm in that category. I don't exactly know what caused my fibromyalgia, but I've spoken to many people and they'll say it's when I gave birth or after that car crash. They can pin down when fibromyalgia started to rear its head. So it's quite difficult to clarify that further. That's why we need more research. But the diagnosis itself, I think perhaps with some people trying to identify where fibromyalgia first occurred, it's quite difficult because it takes quite a long time before you actually get diagnosed. You might not remember that far back for some people. That's a flippant comment, but the average time I think in the UK is something like 2.5 to 3 years for diagnosis, but it's not unusual to get people 10 years, more than 10 years, that they're journeying in order to get that diagnosis, going through multiple doctors, multiple specialties, multiple clinics, locations, etc. It's a complex condition. It's not easy for doctors to diagnose. It's easier perhaps than it was previously. Symptoms overlap with a number of conditions. ME is one of them, of course. But yeah, that length of time to be diagnosed, that's the time that you are perhaps suffering in pain that increases over that time period because your symptoms aren't being addressed. Medication perhaps isn't helping. You've not found what might work for you. And I think the longer that it takes to find that sort of life balance with medication and other interventions, the harder it is, or the more suffering that you potentially, it's not a baseline until you actually find that balance. You might get worse, but you need to find that baseline. So it's being seen, being diagnosed earlier gives you a better chance to find that baseline that works for you. Treating fibromyalgia, there's no cure. You go on the internet, I think there's plenty of people that will suggest otherwise, but yeah, there's no cure at this moment in time. There are treatments, there are interventions, therapies that might actually make life better for you. But if we get 10 people in a room with 3 drugs that are available for fibromyalgia, you might find that 3 work for, or 3 people drug A works for, the next 3 people drug B works for, the next 3 people drug C works for, and then that last person, none of those drugs work for. And that's not taking into account side effects, whether they work well, etc. So it's a journey. We don't have a map. There's a lot of dead ends, and it doesn't help when medical professionals perhaps don't signpost us in the right direction either. We use a combination of painkillers, antidepressants, anti-epileptic medication, as well as things like cognitive behavioral therapy, talking therapies, ACT therapy. They don't address the pain, but they can help you perhaps get a different view in what you're going through. I know this is one of those subjects that when it overlaps with ME, it's one of those contentious subjects given the history and challenge that's within the ME community. Activity is also something that we think is beneficial for fibromyalgia. But the important thing here is you have to listen to your body. It's small changes, increasing over time, but always listening to your body. And if it's too much, if you, again, goes back to the difficulty of diagnosis, if you have ME and there's post-exertional malaise that perhaps might come into things, then that's where the help of the doctor is really required to find out whether that is something that's complicating the balance that you have, or whether the activity is helping. It just adds to the challenges. And the science of fibromyalgia, it's ever changing, but it seems to go at such a slow pace. The name itself is only from about 1976, I think it is. Previous to that, fibrositis and some other names. In fact, you can actually go back, on our website, there's a history page that talks about going back to the 1600s when they were talking about rheumatism, etc. But 1980s, and then latterly the 2000s, we started to have some changes, some understanding. And this informs how chronic pain is understood as well. But these brain scans, I'm just going to, you've got the bottom row of brains, and hopefully you can see the third one along to the right has got lots of green areas on it. What they did in this research is they had pain being applied to people's fingers while they were getting scanned, and it was the same amount of pressure that was being applied, and you would find that the brain lit up a lot more for the people with fibromyalgia than the controls. And if you look at that graph, effectively what's saying, if you apply a pain of 5 to someone with fibromyalgia, then yeah, they'd be screaming. If you apply it to someone without fibromyalgia, the controls, then it might be a slight discomfort. So it just shows you how pain affects people with fibromyalgia. And it started this conversation about the amplification of sensitization of how your brain processes things, the fact that you're more sensitive. And one of the examples that's used is if pain has a volume control that's turned up more in people with fibromyalgia. I always use the example of my boy when he was younger, giving me a cuddle, me wincing in pain. I think it was after football, and him pulling back thinking he hurt me. It's something that, again, it catches me every time I talk about it. I still remember that look in his face. But that's just that example of the pain dial being turned up and some innocuous contact, a cuddle, basically causing a negative effect. Now, within this as well, we have evidence of things like substance P, growth factor, and glutamate. To simplify things, you have pain processing that goes up towards your brain, and then you have pain processing that comes down from your brain. And those substances are to do with how the pain gets to the brain, whereas things like serotonin, you'll have heard of SSNRIs, the brain processing pain in its way back down. That's what these drugs are trying to change, to modulate, to make it your body behave better in how it deals with the pain. But the last thing in that list, the fact that we have other factors like small fiber neuropathy or autoimmune, these are the best theory that we have at this moment in time is the fact that it's a central nervous system condition. There's things going on within the brain that are misfiring that we perhaps need to understand more to then improve the therapies that we have. But we also have things like small fiber neuropathy that's present in a lot of people with fibromyalgia. I think it was 25%. So it's not everybody. And then we've always had this conversation about whether fibromyalgia is an autoimmune condition. We have a lot of overlap with autoimmune conditions. A lot of people that are taking therapies for autoimmune conditions, as well as having fibro. The diagnostic criteria actually made it difficult for people before 2016 to be diagnosed with fibromyalgia if they already had a pre-existing condition, because it would be put at the foot of that pre-existing condition. But recent research, you might have seen it in The Guardian and elsewhere, we have some evidence that in taking some autoantibodies from mice and transferring it to other mice, they can actually transfer the symptoms of fibromyalgia from one group to another. And that sounds really interesting, but whether it's that research or whether it's any research that just has broken ground, if you like, we need it to be validated, we need it to be replicated. And then the distance between that happening and an established theory rather than a hypothesis, we need it then to make the distance that it needs to travel towards being a therapeutic. That's a long distance to travel. There's a lot of questions to be asked. I would still say at this moment in time that our best theory is a central nervous system. There's still questions to be asked about that study that was carried out. It was focusing on pain. There's other aspects to fibromyalgia as well that it wasn't addressing. We need more. We need more information. We need more research. We need more time to spend on that. So at this moment in time, the conversation around about it being an autoimmune condition is one that will continue. It was going on even before now, but there's no conclusive evidence at this moment in time. But there's more evidence, more understanding about where we are with regards to how the brain's interacting within this condition. So that's where we're at with regards to the science. Obviously, I've just covered it very briefly. But it's people that are at the base of this condition. It's myself, how long I've been dealing with it, and the career that it's taken away from me, the challenges that it is put in front of me. And we have two case studies here, one about employment, one about a university education. And they're intentionally about young people, because at the moment, or actually not at the moment, but when I first got involved with the charity, I think it was around about 34, 33 that I was diagnosed. I was male, I was relatively young. It was unusual for me to be diagnosed at that time because we had a stereotype of a woman over the age of 40, perhaps with anxiety or depression playing into it as well. If you presented to a doctor in that category, then fibromyalgia was very likely to be diagnosed. But if we use the tender points, it used to be 18 tender points. If you had 11, you would be diagnosed. If you had 10, you wouldn't be. Now, what happens to that person that's got all the symptoms to do with fibromyalgia, but they only have 10 tender points, they're male? My physiology is different from a female's physiology. That's one of the things that perhaps has changed for the diagnostic criteria, why more males are being diagnosed. But these people here, Rachel and Kelly, they're a face of fibromyalgia. We have a very diverse community that suffers from fibromyalgia. And one of the things that we've been doing recently with the charity is talking more about that diversity, because that diversity needs to be recognised so that doctors don't pigeonhole people and our community doesn't pigeonhole people. We need to see through other people's eyes as well. Now, it can take away your career, it can make your chosen job more difficult. It can take away, if you're going to university, it can make your life significantly harder. We tend to be people with this condition, though, that try to strive beyond the challenges that we have. Certainly a lot of people that I know are type A personalities that try and go beyond this condition. So when you have somebody that is trying to do more with this condition, whether it's in employment, which I'll talk about in a bit, that's why we want to keep them in employment, because they're motivated to actually go to work, to go to university in spite of our condition. So you want them to succeed. Now, the charity, we've got a simple mission, and it's all about improving the lives of people with fibromyalgia. And the primary goal is doing that through awareness of the condition throughout the UK and elsewhere, but also to improve awareness and access to treatments for the condition. That's a little bit more complicated now that NICE have decided that certain things perhaps have a good evidence standard in order to be provided to people with fibromyalgia. So some of the things have been taken out of our toolkit if we follow NICE's guidance, but it's still down to an individual health professional's judgment. So I can talk a little bit about that as well. But that's why awareness about the condition and awareness about treatments is so important. Whenever I participate in the helpline or attended support groups, frequently it's the case that people will say, I've tried every medication that's out there, I've tried every treatment, I've tried everything. I'm at the end of my tether, there's nothing that works. I ask, what have you tried? And I have not met a situation yet that there hasn't been something that has been available that they were unaware of. It's not to say that it will help them, but that's why awareness is so important. We need to increase awareness of fibromyalgia. It's doing a lot better now than it was, let's say, 20 years ago. We need to improve access to treatments to make more treatments available and not less. And we need to provide support to the people with the condition, especially those that are newly diagnosed. Who's at the centre of the charity? Well, it's always been directed by volunteers. I'm one. Staff, we've added to over the last few years. We went from, if we use full-time equivalents, I think we used to have a third of a person as a full-time equivalent. Hazel, and before her, Chloe, as a part-time worker. But now we're around about 3 full-time equivalents. And that means, I don't know if you've seen our Awareness Week activities, a lot of social media and events such as this. It takes a team to put it together. It takes our trustees to help direct the charity, but it takes the team to make sure that, well, I end up sitting here and we end up with content that goes on the website and all the things like getting support books, getting first inquiry packs out to individuals with a condition or out to support groups. So these staff allow consistency and allow us to help the gamers that are fundraising with us or for us this week as well. And yeah, without that team, we wouldn't be able to do what we're doing now. But we also have volunteers like our regional coordinators that direct people towards groups and support people, our office volunteers, medical professionals that give us advice on our advisory board, and the people that help run our national helpline. Without volunteers, we wouldn't be able to do what we're doing. And with what we're doing at this moment in time, what is it? And it's providing information, presentations like this, information to medical professionals. Our national helpline for benefits, or just the general helpline, is busy all the time. People that are just newly diagnosed, that might be their first contact, and then they'll get a first inquiry pack sent out from our office. It's not just first contact. Obviously, people have things that come up. Support groups have issues. We've got about 150 plus around about the UK, hoping that they're going to start resuming physical meetings quite soon. Some have still to decide what they're going to do. But we've got online support groups like our Facebook group. Health Unlocked allows for anonymous posting of information. It's a great community there as well as things like Twitter and other channels. And we've got awareness raising campaigns like what we're doing through Awareness Week now. Gaming for Good is one of the things that led into Awareness Week. We were trying to find something that would allow people to fundraise for the charity while having the condition itself. Great North Run or a marathon, yeah, that's outside the reach of people with fibromyalgia a lot of the time. So we're recognising the fact that we want to get people to find an activity that we can participate in and support people doing, as well as obviously gaming. Some people use it as a distraction technique. So that's why it's at the centre of the Awareness Week this week. But there's other challenges going on as well. But these pictures, yeah, people jumping out of a plane is a common thing. Somebody recently went and strapped themselves to the top of a biplane doing a wind walk and did a video about it. Yeah, people are nuts and do lovely things on behalf of the charity. We couldn't do what we do without them. The middle picture, I think it was a group of airmen. That's the Falkland Islands. They recreated the walk from Port Stanley to Goose Green, full pack, 24 miles, I think it was, and then get lifted back to base for a well-earned rest in a big giant Chinook helicopter. So yeah, people are doing things for us, and it's brilliant. Right hand side, that's an employer that was doing we did one of our presentations to them, but they were doing things like cake sales, dress down days throughout the year. And we've got another charity partner that is doing, they did a Tough Mudder for us with 39 of their employees doing that. It's not just about the funds that they raise, it's about the awareness that that campaign generates as well. And we've also done other things. These are just a couple of examples. If the picture of a man, that was one of the ones that we started, I think about 2 Novembers ago, when we started to try and think about widening the view that people have about the condition to feature more males, more young people, feature the diversity that's within our community. And the picture on the right-hand side, again, a large group of people in a big crowd. Some of them are yellow, some of them are purple. We don't have any visual indicators for people with fibromyalgia. We walk amongst everybody else. There's more people that have this condition than we know. And it's often said that once someone is diagnosed with the condition, they talk to their family, and yeah, then it comes out, oh, your Auntie Gemma has that as well, or this other family member has it, or that's that thing that whoever has. So that's why awareness is really important, but it is very basic. The information pack, what we send out to people, let them know about what we know about the condition, signposting them to more information. That first inquiry pack, or turning up to a support group such as your own, when that person suddenly realizes that they're not alone, that other people have walked this path, and that there is support, friendship and help that's there for them. That's why a first inquiry pack and information pack going out to people is the most important thing that we do. So that's pretty much me. I'm hoping that I've covered most of what we needed to talk about, but I'm open to questions. One of the ones that was, if I remember, that was asked before the meeting started was about vaccines and how they interact with people with the condition, and some people feeling perhaps after their first or their second dose feeling a little bit more under the weather, or whether they had a flare. This is something that's come up in our community often, before the vaccine arrived, after the first dose, after the second dose, as people go through the different age groups. And generally, without having any actual qualitative research, very much anecdotal, very much from our communities across the board, some people have it worse than others. A lot of people just have a sore arm. Some people have some symptoms beyond that. But generally, there's nothing that distinguishes our community from the general public. And again, the same applies to actually getting COVID. There's not any increased risk. That was something that we talked a lot about when COVID first came about. But it's obviously any condition, or sorry, any additional illness, any additional flare, we don't want that to happen to us. But there's no greater risk. There's no additional impact, if you like, from it. We might have a flare, we might feel worse for whatever reason after getting COVID, just as somebody else will, but there's no rhyme or reason. It doesn't seem to be any great numbers, but some people, again, just as before COVID came around, there was people that would get flares. We all get flares from time to time. We don't know what happens, what started it, what necessarily triggered it, and there's nothing with what the current situation is that allows us to put our finger on that for anybody else either. So hopefully I've addressed that question. But is there anything else that somebody wants to ask? I'll stop the screen share.
Thank you so much, Des. You've covered so much. That's been absolutely brilliant. I've got quite a list of questions now that have come in through both this chat and through the Facebook Live. So please keep those questions coming, and we will continue to pick them up and ask them on your behalf. One of the things that followed on, since you've just mentioned the vaccine, was somebody said they did respond quite badly to the vaccine, and their doctor thought maybe it was because fibromyalgia is an autoimmune disease. You've talked very much about central nervous system. Are you kind of aware of what the current kind of state of science or state of play is about the autoimmune possibility?
So
parallel discussions go on, obviously, in the field of ME/CFS
Yes,
as well.
yes.
So yeah, I'm aware of that. Yeah.
And actually, the researcher presented to a conference in Invest in ME, I think in 2019, when he was first presenting some of the information about this and talking about how the autoantibodies function. I'm not a clinician, but I am across research. But one of the things that we always come back to, actually, and the funny thing, or sorry, not funny, but I don't know if anybody remembers that there was a strong reaction within our community when we had MMRV or something like mouse retrovirus. And for a period of a year, that research was groundbreaking. It was going to change things. It was going to make a big impact. It was the solution. I know there's still some controversy over how that went, but it's an example of how research can happen. But what we need to do is have patience and wait for that research to be replicated by other people in other sites and see what happens. So before this recent research, we've had people saying about autoimmune and have theories, and their theories and the evidence doesn't perhaps get up to a good enough standard yet. Doesn't necessarily mean that it's not true, but we need to wait until we have a good standard of evidence. But the research that was done prior to this to try and look into autoimmune conditions, looking at inflammation markers, looking at rheumatologists, the scientists, they thought a long while ago, and I've constantly thought, that there must be an autoimmune link here. But up to this point, the evidence has not been there. Now we have something that is worth looking at, worth having more research about. A lot of discussion within the community saying this is going to create treatments, this is going to make a difference, this is going to change things. I always knew it was an autoimmune condition, but we're not there. We have research. We have good research that was being done by good people and good institutions. But that good research needs replicated. Until it's replicated, until we've bottomed it out, until we've ruled out that it's not got some other aspect. And it wasn't necessarily about it being an autoimmune condition. It was about it having traits of an autoimmune condition, about signaling that there might be an immune component. But also to go back to what the GP is saying, and about it's because you've got fibro and it's not an autoimmune condition. You're not immune compromised. That's not what an autoimmune condition is. So there's that aspect as well. So unless you're taking medication that perhaps compromises your immune system, you're not then going to be at more risk of catching COVID, for example. So there's a lot of moving parts in this, but some of the words are the same, like immune, but it's not always the same thing. And we need to wait until research is done that gets us further along this path. We can have hope, but that hope must always be tempered by time. I know so many research things that have happened, that have come up, caused a little flare of activity, and then we've not heard of anything later on down the line. So that's why I'm very happy about the institutions that are involved with this and the conversations that I've had with the people involved. We just need more research, and hopefully that will come along when it's due, when it's ready. So,
do you have any suggestions either of kind of names to watch for researchers, and do you have any sense of how much funding is going into research at the moment? It feels like it's very, very low compared to the prevalence of fibromyalgia.
Yeah, I don't have a frame of reference about whether it's how much is enough. I don't think many people do. I don't think it is enough. I don't think there's enough going on. I wonder whether with the money that has been ploughed into COVID and the research around long COVID, that we will have more benefits as a result of that. I think there's going to be political benefits of that. We're now in a situation that people probably realise that all these symptoms can come from something happening within the body, and it's all about all of a sudden feeling how we do without us not knowing what it came from. There's a lot of similarity there. I think that might be more beneficial for the ME community than for the fibro community, but I can only hope that there will be treatments and therapeutics that will come out, because a lot of the same people are looking at that research. But what I would say is, I mean, versus arthritis are putting money into research for the likes of the PACFIND study that's looking at existing treatments, existing clinics, and what people are doing within the NHS and what's working. Now, that might produce some beneficial results. I think it's 1.5 million roughly, maybe a little bit less than that was put into it. It's not going to produce any new therapeutics, but it might get rid of some of the people doing things incorrect or not helpful, and allow us to focus on things that are helping people. So that's one bit of good research. We also have, see, the thing is, you've asked me to name names, and that's obviously the names have now disappeared.
Oh, don't worry.
Liverpool University, I think it's the Walton Clinic. There's Osman, I think his name is. He's actually he specializes in diabetes, but he's looking at small fiber neuropathy, overlap with fibromyalgia, and looking for a test, because at the moment you have to do biopsies to find out whether people have SFN. But he's actually looking at what it would show up when they scan an eye, and so there's overlap with diabetes there, and whether there's the presence of small fiber neuropathy when they do a scan. So therefore, there would be a non-invasive way to quantify how many people have SFN and look at whether how much that exists within our population, what the relevance of that overlap is, and how that can be helpful. So that's quite interesting. What other research is going on? I'm going to run out of ideas, but I don't think it's enough. Daniel Claw, I would always keep an eye on what he's involved with. University of Michigan, he's one of the leading lights to do with fibromyalgia. The slide with the brains, etc. He was one of the reference people. He was under the supervision of Frederick Wolf at that point, obviously the person behind the diagnostic criteria, but he's now leading a lot of research. One of the things that he was looking at, along with others, was neuroimaging of the brain. It's one of the areas that he focuses on, and looked at pregabalin, and they could identify, they already knew that pregabalin didn't work in everybody. If I go back to the analogy I was saying about the third of people, there's FDA studies, I think, that show that medication that might only be 30 to 40% effective, or only in that amount of the population. So looking at pregabalin, using brain imaging, they could identify the group of people ahead of them taking pregabalin that it would not work with and who it would work with. Now that actually has great ramifications outside of chronic pain, but within chronic pain, but just in drug development. The efficacy, the evidence that's used for things like NICE guidelines, sorry for swearing again, but there is if we had the drugs, the trials that we already have, the evidence, and we could rule out the people that weren't in the right group for that to work for, that efficacy level would increase dramatically. Now, that's something, it's not a therapeutic, it's an adjunct to a therapeutic, but if that works, that could be one of the most groundbreaking things for fibromyalgia, for other conditions, for many other conditions. So, Professor Tracy, Irene Tracy, I think it was, she did a nice long, an hour and 20 minutes about neuroimaging and chronic pain for the Footlights Festival. That's something to look at. She did a little bit segment within that about the pregabalin study as well, because I think that the thing that Daniel did about it was in a restricted conference. So yeah, Irene Tracy. But again, anything that I mention that I forget or don't fill in all the details for, let me know and I'll go and find the information, then I can get it back to Carolyn so that it can be supplied to everyone, if that helps.
Thank you, thank you. One of the participants here today has asked whether there's any specific knowledge about how the prevalence of fibromyalgia or how it affects people of colour. Is that something you've got any further information about that you could share?
Within the UK, we don't have those stats. What I can talk to, in fact, sorry, first of all, stats within the UK, it'll probably be different around the UK, but the way that fibromyalgia is quantified most of the time is you see a rheumatologist, they don't have a category for fibromyalgia, so you go into musculoskeletal other. So therefore, numbers coming out are quite difficult, something we would love to work on, and that would give us a better way of looking at things. However, the prevalence, fmauk.org/prevalence, and I think I referenced a study on that page as well, and that's for the stats that I quoted earlier. That was a 5 European country study, Spain being included, as well as a number of others. So that did sample a large group of people. But again, I don't think that had, it might have had in the paper, I wasn't looking at it for this, but it might have had age, gender, ethnicity broken down. But what I would like to talk about is the fact that a lot of the time people have made a connection between whether we get enough vitamin D within the UK, whether sunshine, etc., has any sort of impact on fibromyalgia. And often what I counter with, not to say that it doesn't have an impact, or it might not be relevant, or it might not be helpful, but when we look at other countries, whether it's Australia, South Africa, Nigeria, Kenya, other countries within Africa, where sunshine is obviously plentiful, the prevalence rates are, well, similar, larger. I think the overall worldwide rate is 2% to, I think, 9%. So if you look at that, and obviously the ethnicity of those countries, then I don't think the prevalence really pays any respect to people, no matter what their age, their gender, or their ethnicity.
Okay, interesting. Before this talk, when I looked up the European meta-studies and guidelines that resulted from that, one of the things that came out more strongly is how exercise appears to be providing people with some levels of relief. Absolutely not a cure or anything like that at all, but some levels of relief. And just anecdotally, I'm aware of, and lots of people in my local area who are cold water swimmers. Yep. And warm water swimming as well. I think there is a study showing that swimming has been of some benefit for some people. How much do we know about exercise? Is this really a thing? And obviously it's a huge dilemma then for people who've also got ME/CFS, because they then have post-exertional malaise, and how you walk that incredible rock and hard place path, I do not know.
Yeah. First of all, whether they have diagnosed or undiagnosed ME/CFS, I think is an important thing to have there, because if you've got fibromyalgia and the doctor perhaps has just diagnosed you with fibromyalgia, but you do also have ME or CFS, then and you don't know about it, then we're giving advice, giving information about activity, and you're wondering why it doesn't work. So it's difficult. It's one of the things that comes up quite a lot within the community. There has been quite a bit of research. It's one of those things that they've spent a lot of time on. Things like Tai Chi, yoga, the fact that you can do it seated, you can do it for a certain length of time, etc., build it up over time. They've looked at that. I think the fact that those activities also have a mindfulness component, that's something that I normally talk about when I'm talking to somebody within the community. Alpine walking, I think there was also some research about that. Qigong, there's a number of things where they have looked at and thought, as well as drawing parallels to similar activities, that'll be of help. There has been research. None that I can think of off the top of my head, I must admit. I don't know of any that has been specifically been done with regards to cold water, warm water swimming, but certainly swimming has featured because it supports your weight, etc. Then it's quite useful. Personally, I've always railed against the idea of swimming being recommended, because by the time that I managed to get into the swimming pool, I've already had the journey there, the 20 minutes to get ready to go in. I spend 10 minutes in it, and then I've got 15 minutes to half an hour out the way, and then sitting in the car for however long to just go, why was that a good idea? So it's one of those things that is a challenge for me, but I couldn't live without my daily routine of keeping active. I feel it when I don't do it. Now, there are a couple of people within our community that swear by cold water swimming. I think there's some people talking about the Wim Hof method to try and get to that, about the cold showers, etc., find that beneficial. But I think it's the same no matter what the treatment, the therapy that people are taking. It's down to whether it's right for you and whether it's right for you at that moment in time. To go back to, I mentioned CBT earlier, I do think that that's something that can be helpful for people, but if you're not ready to take CBT, then it's not going to be helpful. If you don't have the right therapist, it's not going to be helpful. If it's not the right time, it's not going to be helpful. So that's one of the challenges. And I know within this discussion in this community, that's something, yeah, that's difficult as well. So, but it's finding a larger toolkit that we can pick from, and we need more tools, not less. NICE have taken some away. They made a judgment on what the standard of evidence was going to be, what was going to be in scope and what was going to be out of scope. So the anti-epileptics like pregabalin, like gabapentin, things like travel, they were ruled out when there is good evidence for them because it didn't meet their criteria. And it wasn't just FMA UK that mentioned it. It was Cochrane who did meta-analysis on the evidence. It was the British Pain Society. It was some NHS trusts, all coming back with the same statement. But if you're having trouble getting off to sleep, then the 1,100 pages of stakeholder comments, you'll see that there's a lot of repetition where NICE have come back and said, yeah, we considered that, it wasn't in scope. Yeah, next. Which is why we would hope that when a clinician is making a judgment about what therapy is ready for that person, they're not going to take away pregabalin. That means that they can get into work, and it's the thing that keeps them with the quality of life that they have at this moment in time, or the tramadol that's allowing them to carry out activity or exercise that allows them to maintain the balance that they've got. They're going to listen to the patient and then think what's best for that individual, as opposed to whatever guidance that's trying to find one solution for everyone.
For guidance, are you referring to the guideline on chronic pain?
Yeah, CPP. Yeah. So that guidance, sorry.
Okay.
And again, sorry, just to, it's a little axe to grind, that I find that the evidence standard that ruled acupuncture in being counted against the weight for evidence that was ruled out, I found that particularly challenging, given that that was the evidence that was suggested for lower back pain ruled it out in that case, where it's ruled in for this. So I think it is very much NICE thinking that, yeah, that won't cause any harm, so therefore, what's the harm in including it? So again, I'm not going to be, it's going to be a welcome comment in the fact that I don't necessarily agree with NICE's priorities and how they do things.
Okay. Could I move to a different I've had two questions which are about pain being one-sided, lopsided, or one limb hurting and not the others. So this idea that it's not kind of evenly spread around the body. And indeed, one of the diagnostic criteria is having persistent pain for 3 months in one limb or 1/4 of the body. So I've read that on the, I can't remember where I read that. So there is this thing of it kind of not being evenly spread. Is that common?
Well, the ACR criteria from 1990 to 2020 to the current one, 2016, does talk about pain and being out in 4 of the 5 quadrants of the body. It's widespread pain. Within the conversation amongst professionals, there is conversation about fibromyalgianess, and that's a term that might become a little bit more common. And if I take you back to the tender point tests and what I was saying about if you got 10 rather than 11, then did you have fibromyalgia? One of the things that's been talked about is the fact that, yeah, today I might qualify for fibromyalgia diagnosis. Tomorrow, I might actually be a bit better and not qualify. So is there some sort of scale? Is it something that perhaps you go into and go out of a little bit? Not that you're symptom free, but perhaps your symptoms come up to a certain standard, this fibromyalgianess. And it's an interesting concept. I don't know if it's welcome to a discussion to talk about clinical things because it's hard, it's nuanced, it's difficult to discuss, but it would help obviously people within the community maybe to think about it in that terms. But as to one-sided, I would always, if somebody was talking on the helpline or at a group and they said they only get pain in one side and it doesn't happen in the other side of the body at all, I would point them towards CRPS, Burning Nights charity, and maybe talking to them and going back to their GP to think about whether there is additional tests or whether they should be looked at. And then again, if the health professional thinks that that's still a correct diagnosis, then we will continue to support them. But the criteria is all 4 quadrants of the body, or 4 out of the 5 quadrants. Think of the head as, I think, is the 5th one. But yeah, it's all over body pain, but it doesn't necessarily mean that you've got all over body pain all the time, right? That's maybe one of the points to mention as well. Right at this moment in time, middle of my back, my left leg, my bum, my ankles, that's sore. I wouldn't say it's very sore, but it makes me move about. But later on, it'll be somewhere else. And if I stand up and walk about, it'll be somewhere else. So I do get different emphasis on where the pain sits for me. So that might be a part of it.
Okay, thank you. There's a question about if you are drug sensitive, particularly to non-steroid drugs. Is there anything else? What else can help really, or how can you reduce that sensitivity at all?
Well, when you're putting a new drug, generally when somebody has a new drug introduced to themselves, you might have it titrated, especially fibromyalgia, step up the dose over time, gabapentin, pregabalin. Often that 30 days that you first have that drug, that's when your body starts to shake itself about a little bit and try to work out what this new substance is, and it reacts. And then after the 30 days, then things perhaps get better. So the titration of the dose, starting on a very low dose and then building it up, gives your body a chance to have a look at it, get used to it before the therapeutic dose that maybe helps you starts to kick in. So that's one aspect, but I guess that's already been done. Non-steroidals, obviously been mentioned. They're mentioned from time to time, but depending who you talk to, depends whether they're actually advised, because we don't have an inflammatory component. They're useful from a pain point of view, and some people have a lot of benefit from them, but we don't have inflammation typically with fibromyalgia. That's what the blood tests look for. That's what they find that it's not there. It's one of the things that sort of gets us away from further investigation of an autoimmune condition, because the blood test come back normal. But you're taking something that might long-term upset your stomach, or you end up taking omeprazole or something else to balance out the fact that it upsets your stomach. So that's something to consider as well. But I know of many people that take naproxen, like it's mentioned a lot, as something that helps them with their pain, because the non-steroidals have these 2 components, helping with pain, but also trying to reduce inflammation. So that's something I think that's worth mentioning. But as to reducing sensitivity beyond titration, the only other thing, sometimes it comes up about the time that you take or how you take the medication as well. It says on a lot of the medication, take with food, and people normally obey it. Some people don't pay any attention to that, but that can be very important depending on the medication. It can actually make the difference between it working and not working. The time that you take it, amitriptyline comes to mind. People take it, you get told generally take it before you go to bed. And some people wake up very dry-mouthed, groggy, unpleasant feeling. Yet if they take it 2 hours earlier, or maybe vary it according to what works for them, they still get the therapeutic effect of much improved sleep, a little bit of lessening of muscle pain, but the grogginess, the dry mouth, they don't have that as much the morning after. So sometimes the sensitivity is about application as opposed to the drug itself. Talking to a support group about what other people went through and how they've adapted, that's something I would always advise, because you might get some nugget of information there that might be worthwhile. And the other thing is sometimes something like a slow release patch for some people might be more appropriate than taking a pill. there's a variety of ways to approach it. So try to find out what works for an individual. Again, journey without a map and a lot of dead ends is the analogy I always go for.
I'm really picking up very, very strongly from you that there are so many individual potential responses to all the things that are potentially available. What are the best kind of forums? Where are the places where people have those conversations with each other? And one of the things we're wondering about is, would it be useful on the Sheffield Group's webpage to have a forum thread which is specifically around fibromyalgia? So please put any comments in the chat if that's something you'd find useful or of interest. But what are the other main forums where people have that conversation?
Well, there's plenty of Facebook groups out there, and I'm always going to say, no matter whether it's a Facebook group, whether it's the NHS website, whether it's WebMD, always have a look at the sources used for the content and the suggestion that's being made. NHS, you're probably going to be okay with what's put up there without having a second thought. But whenever anybody says something, and I get myself into so much trouble interacting on communities because I automatically walk in with, yeah, prove that. Tell me that that's right. What's the source? What's behind it? Because there's so many different little strands of information and things going on out there that just don't have evidence. But we've been a little bit late to the party with a Facebook group, just started up, I think, around about Awareness Day this year, because there was already other Facebook groups out there. And we thought, yeah, let's not get into that. But we've got a nice group there. It's growing very steadily. It's got, yeah, a few thousand people on it. We're very careful about we don't censor things, but there's not going to be any selling or anything like that. If something doesn't have good evidence, or CBD cannabis, it will be discussed, but there's going to be a lot of people that are then trying to sell, or from the US or wherever, that are trying to post things and suggest that this herbal remedy or that. So that's one of the things that we're always mindful of. But the Facebook group is a good place to have a conversation. Health Unlocked is a good site for not only our own community, but for other communities. One of the big benefits is, and also one of its troubles, is the fact that you're completely anonymous on it. So you can be confident that you're posting your own medical information and getting advice, and then get what you need from it and perhaps go elsewhere. So that's quite a good community if that's one of your concerns. A lot of the time, even on the Facebook group, you've got the ability to do an anonymous post. One of the things we don't talk about is intimacy issues with fibromyalgia or health conditions. So sometimes that aspect of anonymous allows you to have those questions, get some support for an area that you don't feel comfortable just going out and talking about. So that's something I think is worthwhile. But also keep across our Twitter page and whatnot. That's worthwhile as well. But there are some good groups out there. There's one across in the States for a group, well, for men with fibromyalgia, because it's difficult for a lot of males within fibromyalgia communities, that with that gender balance, with topics that don't normally fit how the need for their support needs, etc. So there is a group called Men with Fibromyalgia. It has its hiccups, but if you are a male that's looking for support, then that's maybe something to look out for as well. It's one of the areas that I think we need to do more in as well.
Brilliant. That's really, really helpful. And obviously on the Fibromyalgia UK website, that's a place where people can find all sorts of information and booklets to download, and that's something that presumably you managed to keep updated somehow with in your
content-wise design. We're in the process of hopefully making it look respectable for the current year that we're in, as opposed to the aged look that it has at the moment. So hopefully that gets a refresh quite soon.
Okay, there's been a couple of queries which are about alternative and natural remedies, or herbal and natural remedies rather than alternative therapies. Are there particular herbal and natural remedies that get talked about quite a lot?
Yeah, there's quite a few. I'm going to a slight aside first of all, because there's a lot of people that say that they are medication free and they're going all natural, and all natural is the best thing. Whereas I always use the example that there's plenty of natural things that aren't good for you either. And even within herbal treatments, there's things that can counteract with medications that you take or things that you have to be aware of. I'm also a little bit concerned that sometimes that people are so keen to say that they're medication free and medications are bad, that they potentially crowd out people that are having that are finding the balance using medications. And it almost goes back, somebody made the point to me when we talked about this before, that there was a time when people were going on about natural childbirth and being without medication, it was the best thing ever, and you were shaming mothers to the point that they shouldn't be seeking medication. And I think we have an element of that within our community sometimes as well. So again, it's a toolkit that people need to dip into that works for them. Some people talk about magnesium, that's helpful. Even lavender or Epsom salts baths are something that's useful for people. I think CQ10 is mentioned, but all these things, I think there's a lot of commonality here with ME community as well, because it's to do with energy production, it's to do with how the muscles are feeling, etc. Some people talk about St. John's wort as well, and valerian, and we've also had melatonin. Obviously, the situation with that being a prescription only across here, some people talk about that, but the evidence base, yeah, it's quite weak, to be honest, but some people find benefit. Now, whether B12 as well, that's in vitamin D, they also come into it. I feel, certainly with the vitamins and the supplements, that you should always try and go and get tested by a GP to see whether you've got enough vitamin D in your system. You can make a judgment about whether how we measure it in the UK as opposed to what the recommended dose is elsewhere, and do a judgment based on that. But if you find out that you've already got the right level of vitamin D and then you take more vitamin D, yeah, probably the risk isn't too much, although there are some. But really, you're just spending money and making more expensive pee. It really is something that you should look at and think about, do I need this? As opposed to, I'll just try anything. Because you end up spending money after things that perhaps aren't going to benefit. And I mentioned PackFind earlier, and we just retweeted a video that they created with Versus Arthritis about the journey that people with fibromyalgia take. One of the things that they talk about is the fact that people will seek treatments outside the NHS because of wait times, because of lack of attention, because of the lack of good treatments. And they emphasize the fact that you're spending money on things, and it can be a good part of your income. So just be careful. It's one of the things that I feel quite strongly about, the fact that, yeah, good evidence for treatment, because people shouldn't be paying for things that really are to do with bettering their health and wasting savings.
And there's a really delicate balance, isn't there, between the kind of stress that it causes to kind of pursue things and to arrange things and arrange appointments, but also the stress caused by, you know, not being listened to by your GP, or not being believed, or even, so do you have any kind of easy, good, short ways of describing fibromyalgia? Because people are often in difficult situations with family and friends who don't fully get it.
It really depends on the situation that people are in. You've got things out there called letter to normals, which comes across as quite an insulting term sometimes, but it's normally quite appropriate for people in that family situation where you have a challenge. I can explain fibromyalgia, the fact that it's an all over. The normal analogy we use is, imagine that you had the flu and then you did 10 laps in a swimming pool and you're just coming out of that swimming pool. That is how some people with fibromyalgia will feel. But analogies only work with people that they work with. They don't always break through. But being constantly in pain, having difficulty sometimes finding words for the simplest of things, feeling tired, getting stressed out by everyday activities, that could be another way to explain it. But it's different for different people. But what we do have is we've got in our information booklet something that explains it. We've got a young person's booklet that does a good job of explaining it to a young person with fibromyalgia, even emphasize it's primary school age up to, let's say, 16, 17. So it tries to cover that age range, and it explains fibromyalgia in good terms, like spelling out difficult words like physiotherapists and using sounding language. So yeah, we've got those things there, but it depends on the situation what might be appropriate for the individual. Yeah.
Thank you. So I think I'm going to wrap up now. I think we've covered most of the kind of question areas without necessarily asking all the very detailed questions about individual conditions or individual challenges of living with fibromyalgia, but it sounds like those would be kind of best discussed on some of those forums, rather than, since you're not clinically trained, there's a limit to how much you could actually respond to some of those individual queries. But I think you've given us an amazing overview of fibromyalgia, which has been really, really helpful, and talked us through all the kind of current issues around the disease, and also describe the work of Fibromyalgia UK. So can I just say an enormous, massive thank you. We've had a couple of interesting things going on in the chat, particularly thank you to Rachel and Aura, who've been talking about whether there's a need to champion fibromyalgia and how it affects not people from people of colour, but particularly how people from black and ethnic minorities actually access support and services, and whether they're believed or treated in the same sort of way, or receive the same kind of support, or can access the same sort of support. So I think you've got some offers for some support there for Fibromyalgia UK, if that's something you wish to take forward.
Can I say just a little bit? If I give email address of head.office@fmauk.org, and we can supply that afterwards, that's how people can get in touch for something like that. One of the things I'm keen to is, last year or the year before, we put up a picture that had the faces of fibromyalgia, and there was a lack of diversity with regards to ethnicity within that. I'm looking for people to represent themselves in case studies, represent themselves by putting a picture in a collage like that, and tell their story, and how, again, one of the things, it's that diversity of our community. More stories, the young, the old, everybody, I think, should get a voice within it. We're also looking for, or actually, I'd speak particularly with people of colour accessing services, since you mentioned that. There's always been this historic aspect, the fact that pain levels are always thought to be inflated. There's connotations, there's all sorts of things that are baggage that's there, that I can imagine that's having fibromyalgia as well is just going to make, it's going to be a more difficult challenge for somebody, a person of colour, rather than perhaps somebody like myself. And it's not an easy journey in the first place. So anybody that has ideas, we need more volunteers, we need more people within the charity. There's many stories, many opportunities that we need to tell or take advantage of. So please do get in touch. Okay, could you just mention that email address one more time, and we'll pop it in chat? Yeah, it's head.office@fmauk.org. Okay, thank you. Great. So a massive thank you, Des, for sharing this time with us, and for just an incredible amount of information and knowledge that you've shared. And we really look forward to continuing strong links with you from the Sheffield ME and Fibromyalgia group. And I hope that we can work together in the future going forward, and do everything we can to support your campaigning and raising the awareness of fibromyalgia. And it's certainly a very kind of interwoven path, isn't it, with people with ME and CFS, because there seems to be just such an increasing number of people who are getting diagnosed with both conditions, as well as other similar or related conditions. So massive thank you to you, Des, for joining us this afternoon, and thank you very, very much to everybody else who's come along today. Thank you.